So now we're going to talk about pacemakers, both for bradyarrhythmias and cardiac resynchronization therapy. And let's go to the questions here first to give you some time to look at these ECGs. So this is a 34-year-old male, usually healthy and vigorous, enjoying a full range of activities. He seeks evaluation for 2 weeks of fatigue and malaise, and he has this electrocardiogram. And you can go ahead and put the question up on the other screen. So what should you recommend? Observation, additional blood work, an EP study, or a pacemaker? Okay. A 75-year-old male, symptomatic sinus bradycardia, and pauses. His ECG is otherwise normal. He's on no meds. He's otherwise healthy. And at the time of his pacemaker implant, there was no AV block at high atrial pacing rates. Which of the following pacing aids would be appropriate? Okay. Question number 3. Which pacemaker behavior is not shown on the recording below? Oversensing, failure to capture, undersensing, triggered pacing, or failure of ventricular output? Looks like you have a teaching moment, Raul. Question number 4. A 65-year-old female with idiopathic dilated cardiomyopathy, exertional dyspnea at 1 block and 1 flight of stairs. 6 months ago, she was hospitalized for pulmonary edema and orthopnea, which resolved with appropriate medical therapy. She's now taking carvedilol, furosemide, lisinopril, and spironolactone. Blood pressure is 100, pulse rate is 58. Her lungs are clear, her JVP is normal. S1 is decreased, S2 is paradoxically split, and S4 is present, and there is no murmur. Chest X-ray shows a big heart with normal pulmonary vasculature. Her ECG shows sinus bradycardia at 55 with left bundle branch block, and her QRS is 135. Her echo shows an EF of 33%. She goes 300 meters on a 6-minute walk. Her exercise pulse goes up to 100. Which would you recommend which of the following? Decrease your carvedilol to allow increased heart rate. Implant a single chamber ICD for sudden death protection. 2, conventional dual chamber ICD program DDDR for sudden death protection and atrial pacing for conotopic competence. C, cardiac resynchronization dual chamber defibrillator. Or D, single chamber ICD for sudden death protection and referral for LVAD as destination therapy. Okay, it's my distinct pleasure to welcome Dr. Raul Espinoza to talk to us about pacemakers. Raul does work with pacemakers and planning the devices, troubleshooting the devices, helping people like me understand the devices, but he also does a lot of other things. He works in the pericardial clinic and the Marfan clinic, and is one of the guys that can really take all those really complex patients we see and work through them in such a logical, subtle way with his patients. It's really amazing to see. And Raul, thanks for being back at the board review course this year to talk to us about devices.
Thank you, Steve, very much. It's a pleasure to be here with you today to talk about pacemaker cardiology for your board examination. I have no disclosures. The first learning objective I've been given is to list the indications for permanent pacemaker implantation and perform appropriate device selection for specific patients. Now, the indications for permanent pacemaker implantation have been reviewed in 2008 and in 2012 in Society Consensus Guidelines. I'd like to emphasize for the purpose of our discussion that the 2008 and 2012 guidelines are unchanged with regard to bradycardia indications for devices. The 2012 guidelines simply represent an update in indications for cardiac resynchronization therapy. So you'll see my discussion of indications for pacing refer to both the 2008 and 2012 guidelines. Now, if you read those guidelines carefully, I think that two broad themes emerge that can guide both our approach to the patient and our preparation for the board examination in such a way that we have a little more simplified and easily carried mindset. And the two broad points that these guidelines illustrate that I think we should try to commit to memory are the following. Firstly, if you have an irreversible and symptomatic bradyarrhythmia, permanent pacing is indicated regardless of where in the conduction system it originates and what the prevailing heart rate is. The second point that I would make is that in patients who have an equivocally symptomatic bradyarrhythmia or an asymptomatic bradyarrhythmia, the risk of mortality or malignant syncope even correlates primarily with the location in the conduction system at which that bradyarrhythmia is found, such that bradyarrhythmias that originate low in the conduction system, particularly in the His bundle and below, are ominous with regard to those endpoints, and so your inclination in ambiguous circumstances will be to pace. Conversely, those bradyarrhythmias that originate high in the conduction system are infrequently associated with mortality and malignant syncope. So again, under equivocal circumstances, the likelihood is greater that you would observe those arrhythmias. And that's really a consideration that can be stated regardless of the regardless of the rate that the patient shows to you. So let's go through the details of what that means by individual bradyarrhythmia. Starting with sinus node dysfunction, I think the key point to understand is that there has never been a survival advantage demonstrated with permanent pacemaker therapy. So the indication for permanent pacemaker therapy in patients with sinus node dysfunction is based exclusively on the presence or absence of symptoms. So those scenarios would include overtly symptomatic sinus node dysfunction, either at rest or exercise. That's the definition of chronotropic insufficiency. On necessary drug therapy. If a patient has a drug that they can do without and they have symptomatic sinus node dysfunction, you'll of course stop it. But if a drug is necessary and is provoking or aggravating sinus node dysfunction, pacing is appropriate. The patient with equivocal symptoms, and after a careful evaluation, nothing else other than sinus node dysfunction with a rate of 40 or less would be another scenario in which pacing can be justified. Thirdly, the patient with an evaluation underway for idiopathic syncope, who again, after an exhaustive evaluation, is found to have nothing other than the identification of sinus node dysfunction at electrophysiologic study or on ambulatory monitoring. That type of patient could also be advised to undergo pacemaker implantation. Moving to degenerative AV block, as I mentioned, the mortality risk for AV block is related to its location. A supra-His or narrow QRS AV block versus an infra-His or wide QRS escape form of AV block. So we are not going to pace the following forms of degenerative AV block. We are not going to pace asymptomatic first-degree AV block or supra-His second-degree Wenckebach AV block manifested as a narrow QRS. Similarly, we are not going to pace any AV block that would be expected to resolve, such as AV blocks related to Lyme disease, drug overdose, unusual vagal influences, or obstructive sleep apnea. We are going to pace the following forms of degenerative AV block: any symptomatic AV block, and the following asymptomatic AV blocks: high-grade AV block, third-degree AV block. infranodal, meaning a wide QRS, second-degree AV block. Any Mobitz 2 or other second-degree AV block with evidence for an unreliable subsidiary pacemaker, rate less than 40, or pauses greater than 3 seconds. That usually implies that the escape focus is low in the conduction system. And finally, when atrial fibrillation is combined with an AV conduction disturbance, pauses greater than 5 seconds are enough to justify pacing. What about bifascicular or trifascicular block without AV block at the time of your clinical evaluation? The key natural history information to be aware of is that 95% of these patients are free of AV block after 5 years of observation. And so we are not going to pace these patients unless one of the following is also present. The patient with alternating bundle branch block. That speaks to a moment-to-moment, highly unstable bilateral infrahis conduction system, and those patients should be paced. The patient who you're evaluating for idiopathic syncope and has nothing other than the observation of bifascicular or trifascicular block, at the completion of your evaluation, you may be suspicious that you simply have not been able to recognize the presence of intermittent high-grade AV block such that pacing could be justified. The patient with bifascicular or trifascicular block who happens to be in the EP lab, perhaps for other reasons, and is found to have evidence of quite severe His-Purkinje system disease, including an HV interval greater than 100 milliseconds or pacing-induced infrahis block. And lastly, the neuromuscular diseases, such as myotonic dystrophy. For that category of patients, we know that they're unique in the sense that they have unpredictable progression from bivascicular or trivascicular block to high-grade AV block. And as a result, we can justify pacing those patients in the setting of bifascicular or trifascicular block without waiting for the development of second-degree or third-degree AV block. You've already heard about AV block as a complication of acute myocardial infarction. What can we say about the role for permanent pacemaker implantation in those patients? With anterior myocardial infarction, AV block is mediated by infarction of the infrahis conduction system. So those patients are at high risk for symptomatic asystole and death, and so pacing would be appropriate for those patients. In contrast, patients who have AV block as a complication of inferior myocardial infarction, the mechanism is different. These patients have ischemia and heightened vagal tone at the AV node level. This form of AV block usually resolves, although it can take many days, and they should be observed. The neurocardiogenic disorders are difficult, and certainly this construct can be perceived as an oversimplification for certain cases of clinical practice. But for the boards, I think we can stratify neurocardiogenic disorders as follows. For carotid sinus syndrome, which is the observation of carotid sinus hypersensitivity on carotid sinus massage more than 3 seconds, a compatible presyncope or syncope history, the patient who faints when they twist their head to back the car out of the garage, and the clinical context of elderly patients who are usually those who are vulnerable to this disorder, pacing can be justified and is highly effective in preventing recurrent syncope. Vasovagal syncope, which is typically seen in younger adults, has variable cardioinhibitory and vasodepressor elements, both from patient to patient and even from spell to spell for a given patient, such that in the literature it has been difficult to show a benefit to syncope with permanent pacemaker implantation. As a result, the guidelines recommend lifestyle modification, which is salt and water supplementation and self-protection measures, as the first line of therapy, particularly if a noxious provocation exists as a prelude to the spell, such that the patient can anticipate that syncope is coming. Pacing should not be offered as frontline therapy to these patients, even if you're fortunate enough to identify a cardioinhibitory pause in the patient at the time of evaluation. The only circumstances where pacing can be considered is if you have a patient with refractory, cardioinhibitory, neurocardiogenic syncope, and recurrent, perhaps injurious syncope despite full attempt at implementation of lifestyle modification measures. Under those very restricted circumstances, pacing can be considered, and I would not expect that scenario to show up on the boards. All right, let's switch gears a little bit and talk about pacemaker mode or pacemaker device selection. And for the purposes of the board examination, I think we're talking about three related concepts. One is, how important is it to provide AV synchrony to our patients, as shown here and here, but not in this patient? Second, if we're providing AV synchrony to our patient, does it matter whether we're pacing the right ventricle or not? Here we are. Here we're just pacing the atrium and allowing for native ventricular activation. And the third question is, how is the provision of AV synchrony communicated to us in the pacemaker letter code? Well, let's start with the pacemaker letter code. It has 3, perhaps 4 letters that we would want to understand the definition. The first letter of the pacemaker letter code is the chamber in which pacing occurs. Atrium, ventricle, both, or neither. The second letter is the chamber in which sensing is occurring. Atrium, ventricle, both, or neither. The third letter is the tricky one to understand. It is the mode of response to a sensed event. Inhibition, such as a ventricular pacemaker inhibiting with a PVC. Triggering, such as ventricular pacing after a sensed P wave in a dual chamber pacemaker in a patient with complete heart block. Both or neither. And the fourth letter, which we won't spend much time on today, is the provision of sensor-driven pacing, yes or no. Now, time does not allow for a review of the original literature dealing with the importance of providing AV synchrony and the issues of RV apical pacing, but let me summarize in a few bullet statements what you need to know for the board examination. Firstly, it's known from the literature that AV synchrony reduces the risk of atrial fibrillation compared to single-chamber ventricular pacing in patients who are in sinus rhythm. Second, AV synchrony prevents a unique disorder called pacemaker syndrome, which is seen in patients who get a ventricular pacemaker in the setting of sinus node dysfunction with VA conduction during ventricular pacing, such that the atria are contracting against a closed AV valve. Thirdly, we know that RV apical pacing is hemodynamically deleterious, particularly in patients who have pre-existing organic heart disease and are going to pace a lot. So the summary recommendation would be that in patients who have intact sinus rhythm, your pacing system should maintain AV synchrony, and it should furthermore be programmed in such a way that ventricular activation is encouraged, if at all possible, through any one of several measures that essentially prolongs the AV delay. What that means in terms of the pacemaker letter code that would apply to given bradyarrhythmia situations would be as follows. With AV block, obviously the key is that we want to pace the ventricle. So the first letter is going to be V or D if we have an interest in being able to pace the atrium, but for sure it has to be V. So V or A and V, which would of course be D. In sinus rhythm, we want to be able to track accelerations of the sinus rate during exercise to maintain exercise capacity. And so we're going to sense in both chambers, and we're going to have both inhibition and triggered pacing. By triggering, I mean ventricular pacing after a sensed P wave, such as during exercise. Obviously, in atrial fibrillation, if we're pacing for AV block, VVI would be the only mode that applies. In sinus node dysfunction, the key is entraining the atrium with pacing. So the first letter of the letter code is going to be an A if a patient has intact AV conduction and does not require ventricular pacing support, or D. And the only clinical scenario that you need to have perhaps a rough grasp of that would differentiate DDI pacing from DDD pacing is the patient who has sinus node dysfunction but can get their sinus rate faster with activity, and at the same time has some element of AV conduction disturbance that might be associated with exercise-induced AV block, in which case you're going to want to provide triggered ventricular pacing. Otherwise, if the patient has no sinus acceleration with activity, then DDIR pacing would be satisfactory. In the neurocardiogenic disorders, we think that AV synchrony attenuates the vasodepressor response of the neurocardiogenic physiology. And so in sinus rhythm, you'll recommend a DDD pacemaker for the patient who needs a dual chamber device in his neurocardiogenic disorder. Of course, in atrial fibrillation, VVI pacing would suffice. Learning objective number 2, let's interpret pacemaker electrocardiography accurately and use the findings to guide patient management. Well, let's start with so-called magnet mode of operation, which in the pacemaker letter code is going to be VOO or DOO. Sensing is disabled, so the second and third letters are O. Here is a ventricular pacemaker programmed VOO, where it shows no regard for this intrinsic depolarization and paces right through at its programmed rate without any resetting of its time clock. The same idea for a dual chamber device. It paces through the recording, showing no regard for a native cardiac depolarization. So that's magnet mode, VOO, DOO pacing. How about VVI pacing? Well, with VVI pacing, it's the ventricular to ventricular interval that dictates the response of the device to the native rhythm. If prior to the conclusion of the VV time clock, you have a native ventricular depolarization, you interrupt that VV time clock and initiate a new one corresponding to this native QRS. Whereas if there is no native ventricular event, at the completion of the VV time clock, you pace the ventricle and reinitiate that interval. I doubt that it'll be on the boards, but be aware of the existence at least of a so-called ventricular refractory period and ventricular blanking interval. These are intervals during which the ventricular sensing of the device is off, so that the device will not have inappropriate resetting of the time clock in response to things you're not interested in seeing the time clock reset for, such as electrical afterpolarizations or the T wave. But certainly if you have a PVC that occurs very early during the refractory period, it will not reset the time clock, and that's a nuance of VVI operation that can sometimes be confusing. With AAI pacing, we have the same idea. Now it's the AA rather than the VV time clock. Paces if there is no native atrial event at the end of the time clock. The time clock is interrupted and reinitiated if a native event occurs. The board may try to trick you with an AAI tracing and show you this type of scenario where you have a PVC before the completion of the atrial time clock and then a spike on the upslope of the T wave, trying to tempt you into thinking that ventricular undersensing is present. But remember, this is an atrial lead, there is no ventricular lead, and so the brain of the pacemaker can only respond to what it sees in the atrium. So this would be an example of normal AAI operation. Let's spend a little more time on dual chamber pacemaker intervals and electrocardiography because they're obviously a bit more complicated. The AV interval and the VA interval are the two key intervals to understand in interpreting the interaction of a dual chamber pacemaker, typically a DDD pacemaker, with the native cardiac rhythm. The AV interval is the interval of time from a sensed or paced atrial event to the time of ventricular pacing. The VA interval is the time from a paced or sensed ventricular event to the time we're due for our next pacing spike. So just as an example, if the minimum pacing rate is 60, a cycle length of 1,000 milliseconds, and our AV interval is 200 milliseconds, the VA interval is going to be 800 milliseconds. As in single-chamber devices, there is a ventricular refractory period that has the objective I mentioned earlier. There is also something I will introduce to you called the post-ventricular atrial refractory period, an interval after a ventricular paced or sensed event when the device will not respond to an event in the atrial chamber of the device, so that a P wave occurring during this time frame will not be tracked by the device. And this PVARP exists to prevent inappropriate tracking of such things as the T wave. It also exists to prevent an entity called pacemaker-mediated tachycardia, which I'll review for you in just a moment. There are 5 normal electrocardiographic expressions of normal DDD permanent pacemaker function. Let's review what those are. So if you have a DDD pacemaker and there is no interacting native rhythm, so it's just the pacemaker, you're going to see what's called AV sequential pacing. AV, VA, AV, VA, indefinitely. So if there's no native event, you have the expiration of the AV interval followed by the initiation of the VA interval. When it completes, you pace the atrium and reinitiate the AV interval, and so on. A second expression of normal DDD pacemaker operation is so-called atrial pacing. Here, we have a QRS, a ventricular event, that interrupts the AV interval. When that happens, the AV interval is terminated, and we initiate a new VA interval. Pace the atrium, QRS interrupts the AV interval, it's terminated, and a new VA interval is started. A third expression of normal DDD function is the complete absence of pacing. So here we have a situation where before the end of the VA interval, we have an atrial event that interrupts the VA interval and initiates an AV interval. We then have native ventricular activation that interrupts the AV interval and initiates a new VA interval. P wave occurs before the end of the VA interval, interrupts it, and initiates a new AV interval. Fourthly, we have what's called P-synchronous pacing. Here we have a situation where, as one would see in complete heart block, but intact sinus node function, a P wave that occurs before the end of the VA interval. What did I say happens with that scenario? The VA interval is interrupted, and we initiate the AV interval. But now there is no QRS that interrupts the AV interval. And so at the end of the AV interval, we pace the ventricle. That's P-synchronous pacing. We don't see it too often, but pacemaker-mediated tachycardia is one of those classic examples of abnormal pacemaker function, and something that I would anticipate you might be asked to identify on the board examination. So here we have a tracing of a patient who's at rest. He's not exercising. The rate is about 150 beats per minute at the upper rate limit. And on the marker channel, we see that the device is sensing something, pacing the ventricle. Sensing something in the atrium, triggered ventricular pacing. Atrial sensing, triggered ventricular pacing. Let's understand how PMT occurs. So pacemaker-mediated tachycardia is typically triggered by a PVC. And it's triggered by a PVC that has VA conduction, and the device has a PVARP that's too short. So AV sequential pacing, PVC interrupts the VA interval, initiates a new VA interval. Retrograde VA conduction, so retrograde atrial activation from the PVC, it falls outside the PVARP. So it can be acted on by the device with triggered ventricular pacing. If this ventricular pacing event is associated with retrograde atrial activation, and that P wave again falls outside the PVARP, you'll pace the ventricle again, and indefinitely, as long as there's no fatigue of VA conduction. And so the solution to pacemaker-mediated tachycardia is to have a longer PVARP that's either triggered by a PVC, programmed as baseline, or some other modality of PVARP prolongation that occurs in response to a PVC. So the bottom line is that we want to have a longer PVARP either after a PVC or in general so that PMT cannot be triggered. And so now you see that you have a PVC which interrupts the VA interval. There is retrograde atrial activation, but this time that P wave falls within the PVARP, so the device cannot respond to that retrograde A by providing triggered ventricular pacing, and nothing happens. We escape at the end of the VA interval with atrial pacing again. So this is actually the fifth expression of normal DDD operation, which is a ventricular event interrupting the VA interval, which triggers another VA interval, followed by atrial pacing. And so in this patient, in PMT, the PVARP was prolonged. It occupied the atrial activation, meaning that atrial activation occurred during the PVARP. The device was no longer able to track it, and the PMT was broken. Let's turn now to pacemaker malfunction. And there are 4 categories of pacemaker malfunction which you might be asked about on the board examination. Failure of capture, failure of output, oversensing, and undersensing. Failure of capture means that the circuit is closed and energy is applied to the myocardium. So energy delivery occurs as evidenced by the presence of a pacing spike on the electrocardiogram recording, but myocardial depolarization is unsuccessful. And that can be seen in a variety of conditions, most commonly lead dislodgement, exit block, or some other form of lead failure. With failure of output, the circuit is not closed. We do not deposit energy on the myocardium. So there will be no pacemaker spike with failure of output. And this is usually due to the third category of malfunction, oversensing, or an actual interruption in the circuit of the device. With oversensing, we have inappropriate inhibition or triggering of pacemaker activity due to undesired sensing. Examples would include cardiac potentials, hardware noise, myopotentials, or electromagnetic interference. Undersensing is the opposite. We fail to recognize and act on a native cardiac depolarization. And this is usually due to a problem with the lead or an altered cardiac potential. So pattern recognition, I think, is the best way to try and understand these categories. Here's an example of ventricular failure to capture. P-synchronous pacing, P-wave, the circuit is closed. Energy is deposited on the myocardium, failure to create this paced ventricular complex, and with first-degree AV block, we have native conduction and a native QRS here. So that's ventricular failure to capture. Here's an example of atrial failure to capture. You don't see a P wave here or here. Perhaps you'd be inclined to think that that's atrial pacing, but if you take a look at this depolarization relative to this distortion of the ST segment on the 4th beat, and then this early paced beat, the cycle length is equivalent. So this is actually a native P wave that's marching through the recording, is tracked here, and is in the T wave here. So this is isolated atrial failure to capture. Here's ventricular failure of output, not failure of capture, failure of output. In the early part of the recording, we see a good ventricular spike, so it's not isoelectric, and then it disappears and resumes again. And we have the luxury of the marker channel that tells us that the device thinks it's closing the circuit, VP, for ventricular pacing. So this is an interruption of the circuit that is preventing energy from being applied to the myocardium. This is ventricular failure of output. Here's an example of both ventricular oversensing and undersensing. The device is programmed VVI at 70, which means that the cycle length for pacing is 860 milliseconds. From this paced beat to this paced beat, it's 900 milliseconds. So something leached into the circuit to cause oversensing and pacing later than should have been the case. The opposite occurs here, where this depolarization, native depolarization, is not sensed by the device such that we pace inappropriately early. That's ventricular undersensing. Let's be reminded that atrial oversensing in a DDD pacemaker is not going to be associated with a pause in the rhythm, but rather triggered ventricular pacing. And so here's a patient who's pacing AV sequentially at 75 beats per minute, does a myopotential maneuver, pulls the hands apart to activate the pectoral muscles. The myopotentials get into the sensing circuitry of the atrial channel, and it paces the ventricle faster due to atrial oversensing and triggered ventricular pacing. The myopotential maneuver is relaxed, and we then return to AV sequential pacing. Here's an example of atrial undersensing, P-synchronous pacing, P wave that should be tracked in a P-synchronous fashion, but it is not sensed, so the VA time clock expires, we pace the atrium, and then we pace the ventricle. So that's atrial undersensing. Excuse me. Learning objective number 3, list the indications for CRT implantation and select appropriate patients for this intervention. Well, here we have a beautiful example of what we hope CRT can provide to our patients. Patient with a dilated left ventricle with systolic dysfunction. You can see that the ventricular septum here on the peristernal short axis view activates first, lateral wall activates later, and a typical left bundle branch block with a wide QRS on the electrocardiogram. After placement of a coronary sinus lead for resynchronization such that there's a left to right wave front as part of myocardial activation in addition to the left bundle branch block, we see a ventricle that has diminished in size. We have a normal septal pattern of activation and an ejection fraction that has increased markedly. With the electrocardiogram correlate of that, including a negative early deflection in limb lead 1, indicating that there's a left to right element to myocardial activation, and some positive voltage in the right precordial leads, giving the clue to the left to right wavefront provoked by coronary sinus pacing, which would be right bundle branch block in nature if it were occurring in isolation. And so I think it's possible for the board examination that you would be expected to have a basic understanding of the pathophysiology of left ventricular dysynchrony and the rationale for cardiac resynchronization therapy. So the rationale for cardiac resynchronization therapy, LV dysynchrony, involves a temporal dispersion of regional left ventricular contraction. By that I mean the replacement of rapid and symmetric activation of the left ventricle mediated by the His-Purkinje system by a slow right to left myocardial depolarization, such as you would see with left bundle branch block, a nonspecific IVCD, or right ventricular apical pacing. The result of this left ventricular dysynchrony includes several biological observations. Number 1, early and unloaded ventricular septal contraction. Second, reduced DPDT and systolic blood pressure. Third, a prolonged pre-ejection phase and a reduced ejection time. As a result of that, a reduced diastolic filling period. Mitral regurgitation can worsen as a result of discoordinate function of the papillary muscles. And the final common pathway, if you will, for all of this is dilatation of the left ventricle and a decrease in ejection fraction. Now, in the foundational CRT trials, I think that we can summarize the clinical benefits as follows: improved quality of life measures, reduced burden of congestive heart failure hospitalization, reduced mortality, particularly with CRT-D, meaning a defibrillator as a part of the system, but even with CRT-P, or pacing alone. So-called reverse remodeling. The ventricle shrinks and improves in its function, and the parameter that we use to judge that is the end systolic volume, which typically shows a greater than 15% decline or diminution. This therapy is associated with no increase in myocardial oxygen consumption despite improved systolic function. A few points about the trials, both the early and the later trials, that help us make sense of the indications for CRT are as follows. In the early trials, the patients that were studied were New York Heart Association Class 3 to ambulatory Class 4 patients with an ejection fraction less than 35% and a QRS duration greater than 120 milliseconds. In this class of patients, benefit from CRT was identified. More recent trials have looked at Class 1 to 2 patients, particularly Class 2 patients, and have also shown benefit, but that benefit is limited to those patients with a classic left bundle branch block with or without QRS prolongation greater than 150 milliseconds. And the overall response to CRT, depending on how you judge response, is in the 50 to 70% range. So this seems like a bit of a daunting table, but let's see if we can make sense of it in a way that you can take with you to your examination. So if the patient has an ejection fraction less than 35% and is in sinus rhythm, what we need to understand is that the maximum likelihood of CRT response is in those patients who have a left bundle branch block. If left bundle branch block is not present, QRS duration greater than 150 milliseconds is associated with benefit as well. But let's also remember that less promising QRS morphology is allowed if the patient is sicker and therefore you're more desperate to extend a measure to them that might help. And so if we start by thinking of these patients as a function of Class 3 and 4, you'll see that with varying degrees of enthusiasm, CRT can be justified whether you have a left bundle branch block or a non-left bundle branch block morphology with less advanced QRS prolongation, left bundle branch block or non-left bundle branch block with more advanced or more extreme QRS prolongation, with obviously QRS greater than 150 and left bundle being associated with Class 1 because all the criteria are met. But the point is that if you have a Class 3 or sicker patient with heart failure, as long as the QRS is greater than 120 milliseconds, CRT can be justified. With Class 1 and 2 patients, we again have to remember that left bundle branch block is most important, followed by QRS duration. So in Class 2, if they have a left bundle branch block, you can justify CRT for a QRS duration greater than 120 milliseconds. If with this relatively modest degree of QRS prolongation you do not have a classic left bundle branch block morphology, CRT is not indicated in the less sick patient. If the QRS is wider than 150 milliseconds, left bundle, Class 1, non-left bundle branch block now is 2B as opposed to 3 because the QRS is wide. With the Class 1 patients, there is only one clinical scenario in which CRT can be justified based on one of the more recent randomized trials, and that's the patient with an ischemic cardiomyopathy, EF less than or equal to 30%, 2B indication for CRT if they have no symptoms. There are a couple other scenarios I would mention. What about the patient with atrial fibrillation? Again, EF less than or equal to 35% and atrial fibrillation. If the patient otherwise meets CRT criteria, CRT can be provided. If the patient requires chronic ventricular pacing, meaning that there is a bradycardia indication for device implantation, and the EF is low in atrial fibrillation, you can provide CRT to that patient as long as you make sure that you provide a high prevalence of biventricular stimulation. In the patient who has a bradyarrhythmia indication for pacing and is getting either a new pacemaker or replacement of the device, if the EF is less than or equal to 35%, and a high prevalence of ventricular pacing is anticipated, CRT can be provided independent of congestive heart failure class. Learning Objective 4, discuss the ethics of device therapies and apply to patient management decisions. Well, I won't spend too much time with this learning objective. I think that the purpose of this learning objective in the context of a pacemaker or device talk is to drive home the emphasis that we should not allow ourselves to fall into the trap of being exclusively guideline driven in the way we interact with patients about recommending a pacemaker or defibrillator, but to recognize that there can be extenuating circumstances, particularly for defibrillator therapy, where there may be a joint decision made to withhold device therapy. And that decision reflects three ethical considerations: patient autonomy, beneficence, and non-maleficence. So patient autonomy involves shared decision-making that allows the patient to understand potential device benefits and complications and to reconcile those with their values and their overall quality of life. Beneficence is the providing of benefit. Non-maleficence is the withholding of harm. So we're trying to provide clinical benefit to our patient rather than harm. And as a result, let's remember that there are some clinical scenarios where we may see fit to withhold device therapy, particularly the ICD. It's possible that if the patient has extensive comorbidity, they may not really be representative of the randomized trials showing an ICD benefit in what are otherwise the cardiac circumstances of that patient. The patient who is experiencing frequent shocks from an ICD and is miserable, and particularly if they have other health issues that are bringing down their taste for life, may ask that the defibrillator be turned off, or if ICD implantation is under consideration, may ask that it be withheld. And certainly, if, in the case of ICD therapy, if we think the patient only has 1 year of survival ahead of them, that would be a situation where ICD therapy in particular should be withheld. So in conclusion, the following high points to my remarks. For sinus node dysfunction, let's remember to pace only if there are symptoms. With degenerative AV block, the degree of block and the level of block determine the role of pacing if symptoms are absent. If symptoms are present, obviously we will pace. AV block after myocardial infarction, we consider pacing if the infarction is anterior in location. Neurocardiogenic syncope, we pace carotid sinus syndrome. Lifestyle modification for vasovagal syncope. Pacemaker selection, we want to try to maintain AV synchrony and minimize the prevalence of right ventricular pacing. Pacemaker electrocardiography, understand the entities of failure of capture, failure of output, oversensing and undersensing. Remember that CRT indications are based on an ejection fraction less than 35%, New York Heart Association functional class, and both the duration and morphology of the QRS. And lastly, let's remember the patient's autonomy and always seek beneficence and non-maleficence when we're deciding whether to offer device therapy to our patients. Thank you.
Nice job. So in fact, one of the questions you got submitted already says this is an awesome lecture. So
thank you. Thank you.
So let's go through these questions. First one is a 34-year-old male who's usually healthy and vigorous, now has 2 weeks of fatigue and malaise with this 12-lead electrocardiogram, and there's a blow-up view, which I didn't show you the first time around. And so the question is, what do you do? Observe, request blood work, do an EP study, or implant a dual-chamber pacemaker?
Very good. Well, I need to work on my spelling with that question, I see, so excuse me for that. But that, I think there was an improvement in the percentage correct. You know, my guess again for the boards is that they want to make sure you're not going to harm a patient. And so what this question is designed to try and help you think about is remember reversible causes for AV block, in this case 2-to-1 AV block. And in a young, previously active and healthy patient, particularly in this part of the country or the Northeast, you would want to get a Lyme serology to see if they have Lyme carditis with AV block. So number 2, or I'm sorry, letter B, request additional blood work is the correct answer.
So what's the usual course for resolution for that?
Yeah, so it can be acutely a challenge. These patients can have enough bradycardia from AV block that they require hospitalization in the ICU and even temporary pacing. But with the initiation of antibiotic therapy, typically the AV block will resolve within a few days, typically less than a week.
Great. So this is a pacemaker mode selection question. It's a 75-year-old male with symptomatic sinus bradycardia and pauses. His ECG is otherwise normal. He's on no meds and he's healthy. At the time of implant, there's no AV block during high atrial pacing rates. So which pacing modes would be appropriate?
Yeah, great.
Good.
Big improvement. B and D is the correct answer. And what I'm trying to drive home on that question is the critical importance of controlling or entraining the atrium with pacing with sinus node dysfunction. So that excludes A and C. If we pace just the ventricle with sinus node dysfunction, we're going to get pacemaker syndrome, and that's a no-no. So it's B or D. And the only time you would implant an AAI pacemaker in someone with sinus node dysfunction is if you've established the integrity of AV conduction. In this case, atrial pacing to an ever faster rate in the laboratory, showing that they do not develop AV block at age-appropriate maximum atrial rates, and under those circumstances, AAI pacing would be appropriate. So in this case, you can either go AAIR or DDDR.
Practically, would you do an AAIR? Would you do AAIR to start with on this guy, or would you start with DDD?
Well, I think that what makes that question a little operator dependent, perhaps, is that there is in the literature about a 1 to 3% incidence of upgrade of AAI pacemakers to dual chamber devices for the subsequent evolution of AV block. So you have to decide how you feel about that relative to other considerations. A ventricular lead crossing the tricuspid valve, and try as you might, perhaps you give this patient severe TR. If you're going to give them a dual chamber device, you darned well better make sure that the ventricle is activating natively. So if you have a V lead in there for backup, if you will, for the natural history of the patient's conduction system disease, perhaps including AV block, make sure that you have one of those algorithms on that allows for native ventricular activation. So I think that it's a little bit operator dependent, but the younger the patient, the more confident I am that there's no AV conduction disturbance, the more I would favor an AAI device.
Okay, great. This pacemaker strip does not show which of the following: V oversensing, V failure to capture, V undersensing, V triggered ventricular pacing, or failure of ventricular output. So which one of those is not present on that rhythm strip?
Back to the drawing board, sorry. All right, well, I think it's a nice tracing because it shows a lot in one recording, particularly when time is short. So the underlying...
It's particularly nice when it's not a device that you put in, right?
Yeah. So the underlying rhythm is atrial fibrillation. There's a pause here, but if you get your calipers out and look at this interval, these intervals, this interval, this interval, this interval, this interval, this interval, they're otherwise equal. So this is a longer than appropriate pause in atrial fibrillation in what is probably a VVI device just based on the nature of the recording. Atrial fibrillation, and other than this pause, a fixed cycle length to pacing. So this is ventricular oversensing. That also is an example of ventricular failure of output. Right? There's no output right about here where you expected it. Here, we're applying energy to the myocardium with this pacing spike. So that is ventricular failure to capture. Here, the device paced on the T wave barely 300 milliseconds after this QRS. It should never have done that. So it did not recognize the occurrence of this QRS. That's ventricular undersensing. And of course, because of the fact that it landed on the T wave, it provoked a very bad event. Now, I know you're not supposed to have questions that say what is not shown on the recording, but it was the only way that I could introduce a concept for just a couple additional slides that sometimes people have a hard time learning, and that's what is triggered ventricular pacing. That's part of the foundation of DDD systems. So let me show what I mean by that, but here's a summary slide that shows what I just referred to: the oversensing, failure to capture, undersensing. But triggered ventricular pacing basically involves understanding the P-wave response of dual-chamber devices. And these are the 4 programmable modes of a dual-chamber device. What we almost always use: DDD, VDD, DDI, and DVI. DDD pacing provides triggered ventricular pacing with an early P-wave that interrupts the VA interval. So you're sensing in both chambers, and you have inhibition in the ventricle if you have a ventricular event, but if you have an atrial event in the VA interval, you'll have triggered ventricular pacing at the end of the AV interval, as shown here, and that's what gives your pacemaker patients chronotropic competence if they have heart block. VDD is only different in the sense that now we just pace the V. We don't pace in both chambers. So we still have triggered ventricular pacing. That's why the letter here is D and D, just as in DDD. The difference is that because we do not pace in the atrium, if we escape to the minimum pacing rate, we just pace the ventricle. We don't pace the atrium. DDI is just fixed rate backup dual chamber pacing. So we don't have the capacity to have triggered pacing after an early P wave. We inhibit in response to that P wave in the atrial channel and pace the ventricle at the end of the minimum pacing rate cycle length. Same thing for DVI, which is now just of historical interest, but we only sense in the ventricle, so we can't respond to that P wave, and we'll pace the atrium. So this slide summarizes the different P wave responses in dual chamber systems and illustrates the concept of triggered ventricular pacing seen only in DDD and VDD. And so you never saw in that recording, well, firstly, the patient wasn't in sinus rhythm, so it would be silly to have the device programmed DDD. And we never saw in that recording early pacing that occurred with enough frequency, meaning that we see it here, you see it there, you see it in a few places, such that you would conclude that the patient was in atrial fib, the device was programmed DDD for whatever reason, and was in an unhealthy fashion providing triggered ventricular pacing in the setting of atrial fibrillation. So we did not see that, and that's why that's the correct answer. Oh, thank you, Steve. And so that's just an example of tracking of atrial fibrillation in a DDD pacemaker. You see the earlier paced events that occur at multiple kind of random locations, again illustrating how a DDD pacemaker will respond in atrial fibrillation. Just a couple more quick slides that I realized I have. So the way we deal with atrial fibrillation in dual chamber pacemakers is the so-called mode switch algorithm. If the atrial rate is faster than some arbitrary number, 170 beats per minute, the device concludes that an atrial arrhythmia is present, and it reverts to that backup DDI or VVI mode of operation.
Okay, that is a complicated strip. 65-year-old female with idiopathic dilated cardiomyopathy, exertional dyspnea at one block or one flight of stairs. 6 months ago was hospitalized for acute heart failure. Is now resolved after a CHF drug treatment started on carvedilol, furosemide, lisinopril, and spironolactone. Blood pressure is 100, pulse rate is 58, lungs are clear, normal JVP, decreased S1, paradoxic S2, and S4 is present and no murmurs. The heart is big. On the chest x-ray, the ECG shows sinus Brady at 55, a left bundle branch block. with the QRS duration of 135. The EF is 33. They go 300 meters on a 6-minute walk, and the exercise pulse rate is 100 beats per minute. So what would you recommend? Decrease the beta blocker to allow an increased heart rate, and implant a single chamber ICD to protect from sudden death. Go ahead and implant a dual chamber ICD program DDDR for sudden death protection and atrial pacing for chronotropic competence. C, implant a CRT-D device. Or D, a single chamber ICD for sudden death protection and referral for LVAD for destination therapy.
Great.
99%, that might be the best score we've had all week.
You did very well. So the point of this question is that the description of the patient is a typical class 3 heart failure patient with an ejection fraction less than 35% and left bundle branch block. So that would be a class 1 indication for CRT therapy. And all the other answers can be faulted. So you would never decrease the carvedilol dose if under these circumstances, since we know that beta blockade is has a mortality benefit to these patients at the maximum tolerated dose. A dual chamber ICD could be implanted to provide sudden death protection and pace the atrium to faster rates. But again, you have a patient with class 3 heart failure, meets all the criteria for cardiac resynchronization therapy. You should not deprive the patient of that therapy. And lastly, an LVAD as destination therapy would be premature in someone who has not yet been given a chance to respond to CRT. So that would only be considered if they were a non-responder to CRT and were quite ill.
I think we ended exactly on time at 5:10. So thank you so much, Raul, for an excellent lecture.